Welcome everyone. Today we have our another new episode and we will discuss about AI in healthcare. We have our world famous speakers and board of advisor, Professor Rob, Professor Donalds, and Mr. Dan. Professor Rob, how you want to analyze today's topic, AI in healthcare? And remember that in COVID-19 situations, Asia Pacific has a lot of challenges in healthcare system. If you give them some sort of good idea and analysis, because already all of our speaker like you become so popular in Asia Pacific, I am sure our audience love to learn more about AI in healthcare from your comments. Yeah.
Well, when IBM Watson first came to market after winning Jeopardy, which was an effort that was kind of a lark, and then it put so much emphasis behind Watson that it became a product. Initially, its target was healthcare. They employed a number of top doctors, and I met with one of them who indicated on the first trial that he'd been working for 3 years to diagnose a woman that had a strange illness that put her in a tremendous amount of pain, and nobody could figure out what the cause was. And at the end of 3 years, they were able to diagnose what it was and correct her problem. They put her symptoms into Watson after it had initially been trained, and the correct diagnosis showed up in the top 10 recommendations from Watson after a matter of minutes, I think 5 minutes, that Watson came up and identified 15 likely causes for her illness, and in that 15 was this diagnosis, which would have cut down the amount of pain she was in from years to days for the most part, because they would have a set of procedures to go through to identify the illness that she was involved in. Since then, Watson advanced in medicine up until just a couple years ago when they seemed to pull back from it. The problem was training sets. The way that medical information is currently handled, it is isolated not only within countries, but it's isolated within the medical institutions themselves and often within the single hospital. So you can't get access across the data sets. To get around that, the concept of federated data was put forward. And this is where you can go in and look at data sets without identifying the people that the data came from, leaving the individuals anonymous, but still being able to analyze the data. That's kind of where we are now. The pandemic sped up a lot of these efforts to try to understand and get access to the vast amount of information on illness that exists in the world, and then being able to analyze it on a global scale. We're still not where we need to be yet, but that's where we are in terms of trying to close this loop and creating an AI that can eventually take a look at a set of symptoms and identify what's wrong with you and put forth a recommended course of action to mitigate the illness, which is the underlying goal. So that's really where, as I say, where we are right now, as far as I know.
Mm-hmm. Thank you, Professor. Professor Donalds, how you want to analyze AI in healthcare?
Well, I want to support what Rob said, which is that if you think about how deep learning works, is that you have to have large training sets. And one of the problems with healthcare has been independent of AI, is the fact that healthcare was one of the very first industries that computerized. They did it just after banks did. And because of that, every single hospital developed their own system. And so even in little Santa Cruz, the Dominican hospital had a completely different system than Sutter Hospital, which had a completely different system. And over time, when the Clinton administration tried to help standardize the data exchange records, to have a uniform data exchange records. I think a case in point, though, is fascinating, because I have a friend who got relatively wealthy as well. In Finland, it's hard to get very super wealthy because they try and they tax you quite a bit if you at the higher income levels. But he did quite well. And what he did is to try and do that, to get data exchange between the hospitals. Now you think about Finland, it's a top-down medical system. It's owned by the state. So they shouldn't have that problem, but yet they did. And they had a teeny little country had the exact same problem that we do in the United States. And of course, the United States is, the San Francisco Bay Area has as many people as Finland. So the problem is much, much, much larger. So what are the kinds of things that AI can be used for? Deep learning revolutionized AI because it gave us the ability to look at lots and lots of data and find patterns in it basically automatically. And so when you start thinking about medicine, what are the kinds of things that we can do or we can imagine doing that large data sets will help with? And as Rob pointed out, one of them is symptoms. When somebody comes into a medical practice, my wife's primary care nurse practitioner, she has kind of a checklist of stuff she needs to ask them right at the beginning. And interestingly, Google did a project where they got lots and lots of people, healthy people, and have been following them, tens of thousands of people, and following them and asking certain data points about their health and using that as a data set to be able to start understanding what kinds of variations that will happen. And so what they're doing is, rather than taking the standard symptoms that are known on the checklists that are handed out to nurse practitioners or doctors, primary care doctors, that have been developed clinically over the years, they're asking a different question, which is, what patterns can we find in people's health that show deviations from the norm that we can find that might be different or new than the ones that we've been seeing before? And I think that's kind of an interesting and exciting project. I think it's kind of a little scary in a way, but it's something that's being done now, and it's a project that's in process right now. And so my wife actually applied for a job being one of the nurse practitioners that was evaluating the people at that project. So she decided not to do that and did something that was less mechanical. that was a very mechanical job. So that's an example, and we'll talk about more exciting things as the show goes on. I want to hear from Dan.
Thank you. Mr. Dan. Yes.
Yeah, healthcare is a great topic. If we like being alive, it's something that it pays to be good at. Something you hear more and more is that you have to be a partner in your own healthcare. Your doctor's not like some mechanic that's an expert that you take your car to and drop it off and he fixes everything. In fact, we have a problem with what's called iatrogenic fatalities. It's a fancy word that means doctor caused. And I think that's been running as one of the among the top 5, if not the depending on how you count it, could be the top cause of deaths. About 100,000 a year. Medical mistakes. We all hear these stories where they put the wrong part on the wrong patient and things like that. So yeah, AI in healthcare. Again, we should distinguish between so-called artificial intelligence and machine learning. I think we throw around the term AI when we really mean machine learning. There's something called AGI, which is artificial general intelligence, which is what a lot of singularitarians fear might make humans obsolete if we have a system that can solve problems without humans in the loop. We get permanently left behind. But hopefully that's not going to happen too soon. But yeah, doctors, we ask a lot of them. We ask them to recognize reams of data just based on their training, which we're all fallible humans. So I think we could get to a point where if you don't use terms like, or if you don't use systems like Watson to check for science-based medicine, how the diseases and symptoms match up together, that could be the basis for medical malpractice. A lot of these kinds of systems of progress come into play because of the court. They're driven by liability issues, insurance issues. So, like journalists say, follow the money. and if you follow the money in healthcare, you're probably going to see the most change, biggest bang for the buck, so to speak. But there's a new company I just found out about that is able to anonymize genetic data and share it in the quest for disease fighting. And I think this is a very good development. It's something that we were kind of lamenting about in a recent transhumanist salon, that because of health privacy laws, there's all this medical data that can't be shared. And apparently this company called LifeBit has found a way to anonymize the data, the genetic marker data, and be able to make it available as a research data set. So that's a good trend. And I'll turn the floor back to our panel of experts. Thanks again.
Thank you. Professor Rob, actually, one of the things always in the healthcare system, especially developing nations, they face like diagnosis the different kind of disease. Especially the diagnosis like cancer and this kind of things. So do you believe that this AI can help to diagnose this problem in the earlier stage, or is there any kind of technology already invented by the top tech companies?
Well, yeah. So out in Cambridge, there's Path AI. Path AI was developed to look at drugs. Bristol Myers Squibb, the Bill and Melinda Gates Foundation are using it at the moment, and it's designed to make more accurate diagnosis. It's focused on cancer. So you mentioned cancer. So its primary focus is on cancer, and so that's the technology that's being used there. Right now, the AI efforts are really pretty diverse. You've got efforts to identify and develop new drugs. I mentioned Path AI to improve diagnosis. You have AI that's being used in microscopes that's been trained to identify pathogens that exist in samples. So image recognition, which is where AIs do particularly well. And then as we advance forward and start looking at broad scale uses of AI and then combining it with quantum computers, so you can look at massive data sets, global data sets. These should be able to help identify and diagnose illnesses that haven't even emerged yet. One of the underlying technologies that's helping here is NLP, which is natural language processing, which at some point should allow a patient to talk to the AI, express their symptoms, and then have the AI make recommendations as to what to look to more tightly identify whatever is causing those symptoms. And so we continually go from treating the symptoms to actually trying to get to the heart of the disease, which is really what you want to do in any type of corrective methodology. Much of our medical practice today is focused on dealing with and mitigating the symptoms, not really dealing with the core cause of the illness because of our inability to get to that cause. It is hoped that AI can help us transition from largely mitigation to actually correcting, and we can make more progress in removing some of these perennial diseases that come up either annually or exist with us on an ongoing basis, and make them obsolete. And AI is one of the better technologies, or one of the more promising technologies to making that happen. You're muted. Sharif, you're muted.
Professor Donald.
There's a wonderful book called The Checklist Manifesto, and in the book it goes to what Dan was talking about medical errors. And what happened in this book is that in a hospital, I forget where it was in the East Coast somewhere, they had hundreds of millions of dollars of liability because people were dying in circumstance where they were getting infections from from lines being put in them. Something very common when you're in a hospital. They'll give you IVs of antibiotics and pain medicine and saline solution to keep you hydrated and all kinds of things. Once I had a compound fracture, and they had this bottle that was hooked to me that they'd come in every hour or so and turn on, pump something different into me. And if those lines, and there's a very strict procedure for doing that. The person who puts them in has to wear gowns and gloves, and they cover you and they clean you and do various kinds of things. And if those procedures are followed, you don't get an infection. But what winds up happening is people skip a step. They either forget it or they think it's really in their, they have so much experience they believe it isn't necessary. And so what they did in this hospital is they made a list of the steps, and they absolutely required everybody to do every step. And they got each other to watch each other. So a nurse could turn in a doctor for missing a step, and everyone could turn in each other for missing a step, so that what the result was is everyone was doing every single solitary step. And the amount of liability, or the amount of people that died and got sick, and thus the amount of times they got sued, went down to 0, and or at least for that particular problem. And so that is something that when you think about the kinds of things that computers are very good at doing, is being able to have repetitive patterns like that, discover these patterns, and help enforce them. That's an incredibly interesting potential use of AI that could make a huge difference in the medical error issue that Dan was talking about. So I'm sure we'll see a lot more of that, and we're starting to see it. I want to say one other thing about diagnosis. I subscribe to this journal called New England Journal of Medicine, and it's a weekly journal that's very prestigious. I mean, it's one of the top medical journals. And every week they have a case of somebody who had some sort of very mysterious illness, and they track down this mysterious illness and go through the steps that they went to figure out what this mysterious illness is. And that goes back to what Rob was saying about the data, is if it's a mysterious illness and it's a very much of an edge condition, when they're training the data sets, you have to have a very, very, very big data set to make sure that there's enough instances of this very mysterious illness for the deep learning algorithms to actually be able to recognize it, because it has to have been there to train the deep learning algorithms to be able to recognize it. So that just emphasizes the importance of being able to share data between the hospitals and collect data sets that you're able to use big data algorithms on and train the deep learning algorithms. And so what I'm saying there is, if the developing world has as they develop, they have a more of ability than the United States, which I was saying the problem was that the hospitals already had computer systems and they had to backpatch them. In the developing world, keep very much in mind that you should have interoperability between the systems that you're building.
Thank you.
Thank you.
Professor Edward, we are discussing about AI in healthcare. Can you share some of the challenges AI has to apply in this healthcare system, or if we have more good solution for the healthcare system?
Can you hear me?
Yes.
Okay. Okay. Great. Yeah. Okay. Your timing is perfect, because I just happen to be writing a piece right now on. See, there it is, right there. On how to change our current sick care system into a real healthcare system. And so I've got some points I literally just wrote out last night, so I'll give those to you. And this, I'm listening to the discussion. It's certainly going to be an iterative process. It's not going to all come at once, but technology is going to make it possible. Right now, of course, we have more of a healthcare system. You get sick, and then we debate whether you're going to pay for it through taxes directly or with your insurance company or whatever. There are some preventive things that are done. Companies, the insurance companies, like, of course, for you to get a checkup so that you can head off something that's bad in the future. But here are the 5 elements, technological elements, and I've heard Rob and Donald talk about these that are going to create in the future a real healthcare system. Number one, of course, is that the cost of sequencing a human genome has gone from about $100 million in 2001, not counting capital costs, to $10 million in 2007, under $1,000 today, meaning that we can sequence our own genomes and see what we are susceptible to, what diseases, what possible diagnostics tools for understanding the genome and much more about us are getting better and better. A friend of mine just moved from the National Institutes of Health to Boston to do AI work on how to analyze, for example, MRIs of the lower body. This kind of work has been done for years. It's being getting even better. That is to be able to look at your blood, look at your genome, et cetera, and tell where the problems could be in the future, as well as, of course, right now. Number 3, wearable diagnostics. We have the Fitbit, we have the Apple Watch, we have the Aura Ring. These are getting better and better. I have some relatives who, of course, wear their diabetes indicators. So if their blood pressure or their blood sugar goes one way or the other, they can detect that easily. It's going to get even better in the next 10 to 15 years, including with nano injectable monitors into your system. So we'll be able to monitor health in real time. Number 4 is real-time analysis. That is to say, if that data is going into an AI, the AI is going to be able to analyze that data and say, uh-oh, it looks like this guy is about to have a heart attack. The medics are going to be to your door before you even know that there's a problem because of that sort of analysis. And again, this is an iterative process, but this is where the technology is pointing. Number 5 is, of course, preventive. Most of you know, we've talked about this in, I think, previous shows that, for example, the CRISPR-Cas9 genetic editing tool 2.0 has recently been experimentally used to turn off the production in neurons of tau proteins. And it's when those tau proteins clump together that we have Alzheimer's. Researchers are literally experimenting with how to turn off Alzheimer's. The enzyme telomerase, which keeps the telomeres growing on your chromosomes, which prevent you from aging, one of the ways to prevent you at genetic level from aging, was sequenced in 2018. So researchers can now work with telomerase to figure out how to use it to stop, the slowing of your cells reproducing. I could go on and on about this. I just saw a story yesterday about a new series of blood tests that can detect 50 types of cancer that might be coming in your body. There is a vision, and the idea, of course, with these preventive measures is that you may not have the heart attack anyway, because we've taken care of the underlying issues. You might not have the cancer anyway. You might not have the Alzheimer's anyway. So it's not a matter of detecting it. It's a matter that we've gotten rid of it. That is a vision for a real healthcare system in the future. 3 qualifications. Number 1, individuals are going to have to, there's going to have to be some sort of consumer base or consumer choice for the system. In other words, if you take a look at what created the information and communication system that we're using right at this moment, it was people like Steve Jobs playing around and Wozniak playing around saying, I'm going to try this, I'm going to try that. Nope, that one didn't work. Let's do this. And offering services, goods and services to consumers so they get choice. They're empowered. Right now, most people aren't empowered to take care of their own health. because you have such a sort of bureaucratic mess. So that people have to be empowered to make choices. Number two, we have to have an open enough system that we can have the entrepreneurs to take the elements I've just described and pull them all together. I don't know how to do that. I'm not claiming that I do, but there are going to be very clever people, the kind of people who've created the communications and information revolution, who try to figure out how to do this sort of thing, to be the Steve Jobs or the Bill Gates of healthcare. Number three, people are going to have to change some attitudes. And there's going to be a balance. For example, what happens if my AI says, well, you know what, Ed, we don't think you should eat that pastry. It's Christmas time, it's holiday season. You have lots of good cakes and foods. We're not going to allow you to do that because it could be detrimental to your health. There's going to be a balance. I don't want to eat just Brussels sprouts all my life or whatever. I mean, they're healthy. Okay, fine. I like them sort of. But the point is, we want healthcare that still allows us enough free choice that we're not going to have miserable lives because we can't enjoy ourselves. So there's going to be a balance there. So that is the vision for what is possible in the future with all the little bits of technology that you guys have been talking about, we've been talking about. It's very exciting. And what we need to do is raise the consciousness. All of you folks listening, you world talent entrepreneurs, think about how to do this. Maybe you can create it in Malaysia. Maybe you can create it in Asia because we have a messy system over here. We can import these ideas. So that's how exciting these technologies are and what they can potentially do. And we really have to raise consciousness and raise the liberty for the entrepreneurs to engage in these kinds of activities so that we can produce a real healthcare system that will basically replace the current sick care system. Oops, I can't hear you. You're muted. Sharif, you're muted.
Okay, thank you. Thank you, Professor Edward. Now I request Mr. Dan.
Well, some other topic that hasn't really been brought up here is, and Ed was starting to touch on it, I think, the issues of health and medical freedom. Where does your... Excuse me? Is there a problem with my audio?
There's a connectivity problem or something.
Oh.
Actually, Edward, I think it's you because you're breaking up, but I'm not sure Dan isn't.
Maybe we're getting feedback from another. How's it now? Okay.
I hear you perfectly, Dan.
Yeah, I hear you perfectly as well.
I think, sometimes when there's mics open, we get feedback, so we should just unmute when we're speaking and remute when we're done. So I had a friend that lived in Thailand for 10 years. And when he left, he was a guy. And when she came back, she had gotten the gender reassignment surgery. And apparently it was like an order of magnitude cheaper to do in Thailand. And instead of being like $30,000 here in the United States, it was about $3,000 or $5,000, something like that. And the surgeon was very impressive. And Karen was saying, "Oh, Thailand is great. There's no regulation. There's people selling all kinds of herbs and cures, and it's really cheap, and it's like a swap meet of healthcare, and people are healthy, and boy, we have a screwed up system here in the U.S. We've got all this, medical monopoly. The AMA has a patent on the word cure, and you can't treat something unless it's cutting, burning, and poisoning, which is kind of considered allopathic medicine. You either have to use drugs or surgery or radiation therapy. So there is a lot of progress to be made in healthcare choice. I think, you want to take away the conflict of interest in healthcare, because it's often been observed that the average cancer patient is worth about $1 million to a United States Western medicine healthcare establishment. And they will make sure that it sounds crass, but sometimes, when that $1 million of insurance money runs out, so does the treatment. And people tend to, someone should do a study to see if people are dying of things at the same time that their insurance money runs out. Now, I knew of course, the alternative healthcare world. Say again?
I said, I'll work on that study, okay?
Okay, yeah. There's a wide open field for people like Ed and other health freedom advocates to demonopolize medicine. There's a researcher that I had the privilege of interviewing on KUCI when I was doing a lot of college radio shows, Dr. Bob Beck. He's no longer alive, and some people speculate that he was taken out, pushed down the stairs, went into a coma, and they think it was maybe a government functionary that did this to him. But he had a protocol, which you can find online. There's a Canadian company called SOTA, S-O-T-A, stands for state of the art, SOTA.com. And basically, there are 4 very non-invasive devices. Micro blood pulsation, which you do ex vivo. You put little saline soaked pads, and it's just a micro voltage pulsing that's biphasic DC, so you're not polarizing but what you're doing is you're putting like tiny currents into the bloodstream, and electromedicine is really a modality that has not been explored ever since the AMA sort of took command of monopolizing healthcare. So then to deal with the products from the microelectrification, you want to drink ozonated water. You can actually get an ozone generator and bubble the ozone through cold water. And this actually oxygenates the water. And he would actually let you put on a little, at our breakfast meetings we had at Caro's restaurant in Costa Mesa every Thursday, you could put on a pulse oximeter. It would show your blood oxygen saturation. Usually it's like 90%, 92. You drink a sip of this ozone bubbled ice water, and bam, instantly it would go to 100%. It's amazing how much this oxygen would rapidly infuse into your body tissues. So that was the number 2 part of his 4-step protocol. The third part was something called colloidal silver, which you can make at home very cheaply. You take pure silver and you run it through distilled water with electricity, and it becomes a colloid. It's a very, very fine suspension of almost an atomic size suspension in the water. But silver is a natural elemental bacteria fighter. They used to put a silver dollar in the water barrel when the people were on the Oregon Trail in their Conestoga wagons. The water would not spoil because the silver has this antibacterial action. So you can use that internally, externally. It's very safe if you don't overdo it. The final protocol was a magnetic pulse, because you not only have blood that you need to treat, but there is lymph. Most of your body is extracellular spaces. There's lymph systems. So by winding your own coil, hooking it to a strobe light, you could get a pretty good magnetic pulse out of a little real-sized coil. And actually, if you put a washer on this thing, it would flip into the air about a foot, and when you pulse the strobe light energy through it. So you would put this coil over your lymph nodes, and this would complement the microelectrification of his protocol. Now, I was asking him, do we know why this works exactly? And he's like, well, it's still being studied, but you can patent things just based on the outcome, even if you don't know the mechanism of why it's working. And he had claimed to have cured AIDS and Epstein-Barr, and he had a big, thick, file of papers of people that had been cured of all kinds of things. So, he said this is not something that the medical establishment likes. They will shut down people that are promoting things that you can do yourself that don't make doctors rich. Now, I know it sounds kind of out there, infringing, and conspiratorial, but science is evidence-based, and journalists say follow the money when you're investigating something. Cui bono, who's benefiting, and you have to disconnect that conflict of interest, profit motive sometimes when you've got monopolistic systems in play. And Okay, so that's my little story about Bob Beck and his alternative healthcare treatment system. But, you know, the Hippocratic Oath says, do no greater harm. You should start with the least invasive cure that might possibly help. If that doesn't work, you move on to something that's more risky, more invasive. That should be the protocol that doctors follow. Indeed, that's what they swear to when they become doctors. It's written into the Hippocratic Oath that they take. So that's my time. I probably overdid my time a little bit there, but SOTA.com. Russ Torlage is a very ethical guy. Bob Beck personally recommended. This is the guy you should get my equipment from. A lot of people have other versions of it. And I didn't even tell you about the brain tuner device, which is based on some pretty solid science too, for putting your neurotransmitters at optimum levels. But I think that's also at soda.com. So not getting a affiliate marketing fee here, just sharing information. And back to you, Sharif.
Thank you. Professor Rob, one of the important aspects about people privacy, do you believe that when any hospital, they utilize any technology or they use any technology which is based on AI, the patient's privacy will be hampered or anything happening? Something like
well,
that?
that's the nature of federated data. The idea of using federated data is you remove the elements that tie the data to the patient, and the patient's anonymity is protected. So yes, and laws all over the world protect patients' information, and so it's getting around those laws has become problematic with regard to doing analysis at a global scale. But in any case, you can certainly have problems with regard to anytime you're using data for any practice, there's always a chance that that data is going to get out and somebody's going to get compromised. And you have to balance the risk of that happening against the overall gain of what you're trying to accomplish. And of course, do everything you can to protect the data with respect to the patient. So yeah, there is an exposure, but it can be mitigated.
Thank you, Professor Donald. Like, if you help us, the role of machine bias, how we can avoid machine bias from the system.
Well, that's a good question. That in the United States, healthcare is far less available to people who are less financially well off. And so that means that if we do find ways of having privacy within the data that we can share, we're going to wind up with a huge bias towards people who are financially better off. And so there's diseases, for instance, sickle cell anemia is just an example that's very well known, and it's not something that would surprise anybody. There's a genetic and easy blood test for it, but it affects African Americans, and it doesn't affect people of Northern European descent. And African Americans have certain there's certain tests that they wind up with. The healthy level for them is different than the healthy level for people of Northern European descent. So in order to spot those, we have to be careful to be able to make sure we're not having bias in it. And there's statistical methods to do that. We know what percentage of the population has different genetic makeups, and we have to be able to do that. I do want to say that one of the important things that evidence-based medicine, it's very easy to have somebody claim that they cure people by some sort of a method. Faith healers do it all the time. There's people who claim that they can wave their hands over you and cure cancer. There's people who claim that they can pray for you and cure all kinds of diseases. There's all kinds of magic that that absolutely 100% cures diseases. And it's absolutely 100% true that the medical establishment is conspiring to stop them from doing it. Both colloidal silver and ozone have been studied and there's absolutely no evidence that they work. And colloidal silver actually can be toxic. So I personally, I looked into it because I researched it, and I personally wouldn't recommend that you take either of those things. And I think that that's a good example. I know 2 people that died of cancer because they decided that they were going to use alternative therapies, where their particular type of cancer did have treatments that would have probably cured them, at least allowed them to have 10 or more years of life. But they went to Mexico for the cure that absolutely 100% cured cancer, and then they died shortly after. I think it's interesting that it's interesting in this discussion that Jeffrey Hinton, who's actually the person that's credited for creating deep learning, his wife was into alternative medicine. She got cancer. She tried alternative medicine and also shortly died from a kind of cancer that was treatable. So I want to point out that there's a balance there. I certainly think that in some cases there's too much regulation, but our minds have a tendency to like basically look at a single trial. If our minds, our brains, I should say, have they weight anecdotal evidence far, far, far heavier than complicated evidence like statistical evidence. It's very, very, very hard to trust statistical evidence. And it's if somebody tells you, well, I have a friend that took this and they got better, that counts 100 times as much as somebody saying, well, they tested 10,000 people and, they tried it and it didn't work. And people go, well, they're scientists, they have this bias because they're trying to make money and all these reasons that you just throw that out. And the one friend that has a friend, it seems far, far, far better evidence, but it's not. And that's something that we really have to train ourselves to understand. Okay.
Thank you, Professor Edward.
I'm just want to say I'm not saying these are 100% cures. I'm just saying take responsibility and do the research yourself and don't.
Right. Me too. I say that too. I mean, it could be right. It's just
okay.
Definitely look into it.
There are 2 points that have come out here, and I'm in agreement with the.
Sure. Thank you, Professor Edward. Yeah.
Yeah. Two important points I think have been brought up here. The first one is that yes, for all of these discussions and all the technologies and approaches, we have to have a healthy skepticism about them. Part of the problem we have today is that we do have, for example, a Food and Drug Administration that was started with pensions in 1962 in its current form to certify the safe. It looks like Sharif is off. Can you still hear me, guys? Okay, I hope so. Okay, good. We have a Food and Drug Administration that was started in 1962 in its current version to certify the safety and efficacy of medications and medical devices, to be against that. Unfortunately, what's happened over these decades is it has become a stifling bureaucracy. It takes 10 to 12 years and costs about $3 billion to bring a new product from research lab to market. That's a tough study that was done a few years ago up in Boston, and I've done a lot of research on this, documenting it. And partly it's just because you have a bureaucracy of a certain sort, and a lot of times the certification process just doesn't keep up with the technology. In 2019, in April, the FDA solicited input on how to regulate artificial intelligence as a medical device. And you say, what, you mean like a heart valve and all? Because, well, that's their mandate, and it's not a medicine, so I guess it must be a medical device. The point is, we have a very antiquated system. We saw that some of the vaccines for COVID were developed within a couple of weeks, and then 400,000 deaths later in December of 2020, the FDA said, well, okay, I guess we've done some limited tests instead of opening the test to everybody. I guess we'll give some provisional certification for this. That's the one side. The other side, and Donald has made this point. I actually agree with you, Donald, on something. So let's hear it today. Is that the public needs to start educating itself. They have to start empowering themselves, because when it's basically a bunch of experts, whether it's doctors, insurance companies, or the FDA controlling your health care, well, there's not a whole lot of incentive for you to do anything about it. And so we're going to have that kind of raising of consciousness. Most people now can make very good decisions on how to buy a car, how to buy a computer, how to buy a smartphone. 87% of American adults now have a smartphone. Isn't that smart? And so we're going to have to see that same thing. By the way, you mentioned minority communities, and this is kind of an interest of mine. The previous Surgeon General of the United States, Jerome Adams, who's, by the way, an African American, lives in my area here in Maryland. I was at a meeting with him a month or two ago, and he, of course, in January, stepped down from being the Surgeon General of the United States. And he was talking about people who are resistant to taking the COVID vaccines. And he was quite open and honest about saying you find a lot of that in the minority communities, in the Black communities, in part because in the past governments have actually experimented on African Americans in this country. Absolutely despicable behavior. Also, a lot of it is a lifestyle issue, for people in those communities. And so there is going to be an education process, not only for people like us who are pretty middle class, but for minority communities. And the answer is education. The answer is raising consciousness, and that means discussing very specific issues like lifestyle. But the point is, we have to have this open discussion about not trusting the experts all the time. On the other hand, educating ourselves, raising our consciousness, empowering people to start actually seeing they can take their own healthcare into their own hands. By the way, I'll mention, because a couple of you guys have mentioned people who tried alternative medicines and they didn't work and they died. Unfortunately, and I was looking for my copy of Skeptic magazine that has him on the cover. The most famous example in the last 10 years is, of course, the inventor, the co-founder of Apple, Steve Jobs, who, when he discovered he had pancreatic cancer, decided, well, I'm going to try some of these frou-frou approaches, and they didn't work. And then it was too late. The surgery came later than it should have been, and that was a cancer that he might have actually survived. So even one of the most brilliant entrepreneurs in human history died because he was looking at alternative treatments rather than looking at the science. So again, education, people taking their own healthcare into their own hands, loving their own lives so much that they can still eat that pastry and that cookie, but not too many. Okay, that's going to be what we have to focus on in the future. Sharif, I'm going to mute myself and let Sharif.
Mr. Dan.
Yeah, I think health is a integrated thing. It's mind, body, spirit. It's personal, planetary. It's the health of it's what we do as good living beings, as we curate good health for ourselves on all levels and all those around us. And machine learning, or AI, is going to play a huge role in this. I think we have Fitbits that you can put on your wrist that are activity trackers. They will count your steps. And I was thinking, how about an AI mentor that counts your positive steps? Where you program the AI with your life goals, and it makes recommendations about what might be possible for you. I think this is going to be a really interesting, fun topic, because we've already got this ubiquitous environment where basically privacy has evaporated, and the least we could do is use all this missing privacy to give ourselves a level of AI health mentoring. We have the world of smart contracts that have, NFTs have been spoken about, non-fungible tokens, and you can basically, anything you can imagine to put in a contract, you can deploy on the blockchain or on a some kind of distributed autonomous organization, you can do what's called a Ulysses contract, and this is named after Ulysses and the Greek story where he tied himself to the mast because he knew he was going to be passing the island of the Sirens and that the song would be irresistible and he would jump overboard. So in a sense, these Ulysses contracts, they're kind of a future performance pact you make with yourself. Ulysses Pact is another name for it. You can say, if I don't achieve this goal by this time, I'm going to donate $100 to a charity that I hate. It's already going to happen automatically if you don't fulfill the pact. So, this is one way of like these New Year's resolutions that everyone makes and then quickly abandons. Well, thanks to things like smart contracts, we can now use these for our own personal and physical and mental and community health. So maybe that's a stretch when we're talking about AI and health, but I just wanted to put that out there and see what people thought, because I'm sure it's coming. So be ready. Back to you guys.
Thank you. Professor Rob, what's your concluding remarks today?
Like all tools, artificial intelligence can be used for good or ill. The promise of artificial intelligence, especially with natural language processing, is a future where you have a problem, you speak the problem to your digital assistant. The sensors on your body diagnose the nature of the problem, and the end result is you either get medication in the mail or a first responder shows up at your door to save your life. And that's the promise. The problem is, of course, these technologies are incredibly expensive. The pharma industry and large healthcare controls the technologies, and they're for-profit organizations. And so the end result is going to have to be a blend of profitable endeavor, probably too heavily weighted towards the profit, and the effectiveness that I just highlighted, the ability for an individual to get the diagnosis and get the most effective and cost-effective treatment, cheapest treatment available. Resolving that is the role of government, to assure that the citizens are not undermatched against these larger industry players whose motives are profit-driven. And remember, it's far more profitable to mitigate an illness than it is to heal it. The amount of money that goes into medications is massive. But if you cure somebody, the event's over, and regardless of the cost of the cure, it's going to be if it's too expensive, most people can't afford it. But if it's cheap enough, it's not going to generate the same kind of revenues as a mitigation. So solving that problem, assuring that the focus is on the health of the individual and not the amount of money the individual can generate by being sick, would be core to fixing this underlying problem and using AI for the ethical benefit of all.
Thank you. Professor Donald, what's your concluding remark? There is one question from audience. If anyone want to give the response, do you think AI can be a better replacement to analysis of the medical test report, such as CT scan?
I would say it already is. It already is. I mean, that's one of the best uses for it, because you can have lots and one hospital can have a bazillion CT scans that they've done over a long period of time. So they actually have the data, and it can be tagged easily because after a while, you know the results of what happened to that person. So you can be able to say this particular CT scan is somebody who had lung cancer, or this particular CT scan is somebody who had XYZ problem. So you can accurately tag the CT scans, which is the perfect training set for AI and for deep learning. And so then it's actually been being used, and they're very good for radiology purposes to be able to look at CT scans, and they're very good and very accurate for that. That's one of the things. I want to go over something that I've said before. In order to answer the question, does it work or not, you have to use statistical methods. Now, the easiest way to do it would be to say, for instance, you're trying to develop a vaccine for COVID, would be to take a large enough population and thousands of people, and take them and divide them into two sets and have a group of people who don't know what they're injecting, inject them with half of them with water, salt water, and the other half with COVID. And again, half of them with the COVID vaccine and the other half with water. And so then what you look at is you discover, you ask the question, well, how many people that were injected with water for both and no COVID got it? How many people that were injected with COVID and water got it? And you just ask the question, and then basically how many people that were injected with a COVID vaccine and COVID got it? And you compare the groups, and you can find out very easily what the difference is. But that you don't want to go around injecting people with COVID. So then you're faced with a problem. How do you know? How do you get a sample so that you can do that? And so what winds up happening is you have to take a very, very large group of people, because only you don't know what percentage of people are going to get COVID in a sample that you have. And so in order to be able to start asking that question, they have to get a large group of people over a period of time, because people don't all get COVID on the same day. They get COVID over a period of time. So what you have to do is you have to take this very large sample of people, again, give half of them the COVID vaccine and the other half you don't get the COVID vaccine, and then determine in the group that doesn't have the COVID vaccine how many people got COVID, and then and you have to be able to make sure that they're close enough to each other that the results that you're getting make sense. So for instance, if half of the group lives in a city that has a high COVID, a large amount of COVID, your results aren't going to be very useful. So you have to be able to create a situation where the groups are so similar enough that you're able to get an answer. And that's what takes the time. That's the time consuming part. It's not the evil FDA trying to block things or the drug companies trying to block things. And there's ways now that using deep learning, we can hopefully speed up that process. And another way that deep learning is able to speed up the process is once we find a drug that seems to be able to work, like an mRNA, we need to be able to make sure that it will hook onto actually trigger our immune system and do what we expect it to do. And so with deep learning processes, we can actually do billions of trials in a second and eliminate all the possibilities that aren't going to work. We used to have to try them all, and now we can eliminate a huge amount of stuff that we don't have to try anymore, which is a fabulous situation. So I think
it seems like you want to recreate the Tuskegee experiments, and the likeliest place the water will get put is on poor folks who are marginalized without power. I think there are some presuppositions about the value of human life inside your science that I find at least questionable and borderline abhorrent in the way you're thinking about things.
Well, it is abhorrent. I'm not saying we should do it. I'm saying that that's the best way to do it, but we would never do. We did do it that way once, and as you said, the Tuskegee, and it was horrible. We can't do that. Okay. I said statistically that's the best way to do it, but we would never do it. We absolutely can't do it that way. That's horrible. Yeah.
Yes, right, thank you, Professor Donald. Professor Edward, what's your concluding remarks?
It's just this. This has been a great discussion about the potentials of the technology. And by the way, basically doing tests and the sort of thing that Donald was just describing, instead of the sort of trials, is one of the things that, for example, we need FDA reform to allow those kinds of new ways of certifying efficacy and safety to emerge. But my concluding summary for your listeners is, number one, we need an open system in which we don't have experts controlling everything, and it could be when you say private organizations like the American Medical Association and so forth, they're not really private, okay, because they have a certain kind of government certification. You can't be a certain kind of practices without them, and a lot of the fights in the United States to bring down healthcare costs is, for example, to allow certain healthcare workers do certain things that right now it's illegal for them to do. So we need a more open system. On the other hand, and even more important, is we need consumer choice, and we need consumer education. And I think they're going to come hand in hand. That is, the more consumers are allowed to choose how their healthcare, the more they see these options that we're discussing in this program, the more they're going to have an incentive to educate themselves and to do the best for themselves. It's going to go hand in hand. And so allow consumer choice, emphasize education and open discussion and open choice, because we do need a Steve Jobs, an Elon Musk, or a Bill Gates in the healthcare area to do what those individuals have done in their sectors.
Thank you. Mr. Kevin, I know you joined late, but you can discuss on that particular point and give your comments. Mr. Kevin, unmute, please. Unmute, please. Mr. Kevin, unmute, please.
We can't hear you. You're muted.
I'm muted. Sorry. Well, that's okay. If you look at COVID and you look at artificial intelligence and big data, you have to look at zip codes, because zip codes are actually a greater determiner of your health than your genetic code. In Chicago, at the start of COVID, there were really interesting maps of COVID infection in red-lined neighborhoods, which are neighborhoods that were systematically disinvested in by the government. They didn't allow VA loans or the early Depression era loans. So the valuations were lower, and their COVID infection rates were 4 times as much as people like right across the street. You could just find that data. And so, the poverty is a global pandemic risk, and the people who are more infected and getting it worse are in red line neighborhoods in the U.S. That's where I work. And one of the things that's interesting there is that one of the things that makes them sicker is that they are heat sinks because of the lack of valuation. You can't make money planting trees or water features or anything else there. And so I'm talking to some really big climate-focused investors who want to make, a city net zero, right? Well, they have to deal with heat sinks. And to solve heat sinks, you have to deal with redlining and things that are increasing the property valuation so you can make money planting trees. And so this is a weird case where, environmentalists don't really typically care that much about poor folks. They often are about the trees and not the people. That's just in my experience. I was working with a great indigenous reforestation at scale project in Mexico, in Michoacan, that created great wealth for indigenous communities and was reforestation a regenerative way at scale. We had a funder who loved the plan, and nothing else in Mexico is planting trees at that kind of scale and doing carbon capture, but they had no way to include the fact that it was baked on increasing the wealth and livelihoods of indigenous people. That didn't fit on their spreadsheet. As an environmental funder, they wanted to know, were the people poaching? Was there civil unrest, or would they be good workers? And so, the environmental valuations don't include poverty, even though it reduces carbon capture. The same in the city. So, you can't talk about just COVID. You have to talk about COVID and zip codes and systemic poverty that has to be erased to make those neighborhoods safer, to make the rich neighborhoods safer.
Thank you. Mr. Dan.
Yeah, good points, Kevin. I just typed in the comments that I think what you're pointing out is that health outcomes tend to track with inequality, and actually I like the word inequity better than inequality. Just to differentiate, equity is giving people what they need to give them a success opportunity. Equality is just treating everyone the same and kind of doing a broad spectrum approach that is usually not appropriate. And the same holds true for personal success in health. And we're at the frontier age of deep learning, which is a great term. I think I'm going to use that instead of AI and machine learning, because it is a human-assisted process. It's a better paintbrush for the art of living, you could say. And we shouldn't be afraid of these transhuman augmentations any more than we're afraid of eyeglasses or shoes that keep our feet from getting cut up when we're walking long distances. These are all ways that we augment the natural world outcome in ways that are demonstrably better. Nature just cares about organisms living long enough to reproduce, and then they can just die off, because that's the way of evolution. Well, so I reject your evolution and I substitute a better one. So thanks again for this topic.
Thank you. Mr. Kevin, if you want to add any concluding remarks, you can add.
That's great. Thank you. No, I think that's right. I mean, I think, urban resilience is fundamentally different than rural resilience, and it deals with masses of people and people who are jammed into places where they got pushed. We're doing the thing. Let me just tell you this project we're doing locally. It's kind of interesting. I live in Asheville, North Carolina, tourist haven. They're out here for the leaves now. They're all turning. And the foundation of our tourist industry is the Biltmore Mansion, which is the largest house in the country. And it's an industrial scale in a way that you've just never seen before, and it hasn't been replicated. They have their own train spur to feed the kitchens. It's amazing. And the Shiloh community got moved to create the Biltmore and Biltmore Village and the Episcopal Cathedral, and they stayed intact. And hundreds of millions of dollars come in through the Biltmore to the foundation of our tourist industry. That's $1 billion industry. And the Shiloh community gets nothing. So we're setting up a repair fund where, two ways. The tourism authorities love it because it's going to enhance the tourist experience for some people, right? I have to take people to the industrial Biltmore, but I feel guilty. Well, relieve progressive guilt, and also stop for a massage. And which is what Asheville's are a big healing place, but you take action to let the people without power have power, and we give the money that's raised in the tax to the community of Shiloh, and we're working with them on all different kinds of things that actually are related to redlining and things. And so I think it's going to be really interesting, and we have two other cities that want to come in and be sister cities to design this: Chicago and Indianapolis. So, you can take a lot of local action, and there are people who want to take action, and we found some ways to make it really easy for them. So if anybody wants to talk to me about that, I'd be glad to. It's not something we're selling, but it's an assemblage of, kind of open parts that we'd be glad to share and be in a peer group with folks.
Thank you. This is an excellent discussion. Especially, I want to give thanks to all of our speakers, those who joined today's discussions, and they shared their views about artificial intelligence in healthcare system. So thank you, everyone. Besides that, I want to share a few things. World Talent Economy Forum, we are actually planning for writing a books, because today is actually our 408 episode. So we done a lot, and already the government, large corporations, and universities, we are working, even university grant commissions, we are working together. So we have to publish a book, especially our speakers and board of advisors and the speaker, those who want to write articles, they can submit their article in between December, like 31st December. And beside that, as a editorial, I'm working in different scientific committee. So as an editorial with MDPI, I'm working in the as editorial for one of the publishers. We are purely focused on.
I'd love to write an article for that about.
Excellent. Excellent. We love your contribution and all of our speakers' contribution. Besides that, the speakers and audience, those who writing research paper on Nikola Tesla technologies, so they can submit their publications and research papers, and we will publish in the journal, and our journal name is MDPI. which is another impactful journal. So I'm working as editorial. So I request, because I know all of you are very good scholars, and especially the audience, there are many audience, those who are interested to write research paper, like research paper on Nikola Tesla technology, they can write. These are the two things. So we will write on World Talent Economy Forum, we will publish our book. So we need all of your support. I know Professor Donalds, Mr. Dan, and all of our speakers support us a lot. So now is the time that we have to go to the next level. Beside book, we are helping governments for developing policies, and hopefully your help will be very much helpful for the developing nations. These are the two information I want to share. Then beside that, I request all of our audience, please share our content as much as possible with your government, with your corporation, and with academia. Thank you, Mr. Dan, Professor Donalds, for your continuous support for World Talent Economy Forum. Thank you all of our audience for supporting us. Thank you. Bye-bye and take care.